Good afternoon, everyone, and welcome to this webinar. My name is Dr. Tom Badayag, and I'm going to be your faculty for this Nclex review series. Welcome to all of you. I know that I recognize all of you, so I assume that you have attended the previous session, so I don't need to tell you how this goes about. But anyway, let's go ahead and start in the interest of time. Our topic for today is going to be asthma. We all know that this particular disorder is very common, and therefore it's going to be a high yield, meaning to say that there is possibility of questions relating to asthma in the Nclex. So let's go ahead and get started. So what is asthma? Well, we know that this is a disease. It's a chronic inflammatory disease of the airways. And what happens to the airways is it becomes hyper-responsive. And when we say hyper-responsive, there's an exaggeration of the immune system response by the body. And that is exactly what happens in asthma. So let's begin with a discussion of the pathophysiology of asthma. And as I said, this is usually going to be an inflammatory response, and it usually is going to lead to inflammation of the airways. So it begins with the inhalation of an irritant. So I have a blank screen because I wanted to illustrate to you the pathophysiology in simple terms. So if this is a foreign protein, the body usually responds by a series of cascading events. And these events is part of the immune system response. And so what happens when a foreign protein enters the body, usually what's going to happen is that there's going to be antibodies that are going to be produced as a result of the detection of this foreign protein. And one such antibody is what is known as the IgE. IgE is one of 5 antibodies in the body. There is IgG, IgM, IgA, IgD, and IgE. And IgE is the one that are going to be the ones responsible for sensitizing and is going to be released by plasma cells. So IgE is going to be released by these types of cells, the plasma cells, and this is an antibody, and this is going to bind with some types of cells called mast cells. And in addition to that, they're going to also bind with basophils. Okay, so a foreign protein invaded the body, and now we're going to have a release of IgE from the plasma cells, and this is going to bind to the mast cells and the basophils. And so when the mast cells are activated by it, it releases several chemicals, and these chemicals are going to include histamine. It is also going to include prostaglandins, and of course, leukotrienes. All right. So what are the events, therefore, that leads to the constriction of the airways in asthma? Well, the actions of all these are going to cause your airway tightening or bronchoconstriction. Okay, so whenever there is a foreign protein that is inhaled by an individual, let's say it is an irritant. It could also be a cold air, by the way. Now, there's going to be a series of reactions leading to airway inflammation and increase in mucus production. And the early phase is initiated by the release of an antibody, and this antibody is what is known as IgE, or immunoglobulin epsilon, that are sensitized and released by plasma cells. The IgE then bind to mast cells and basophils, and these mast cells and basophils releases mediators, and these mediators include your histamine, your prostaglandin, and your leukotrienes. These substances are going to be the ones that are going to be responsible for causing bronchoconstriction. So this is going to be the series of steps that usually is going to be seen in these individuals that are going to have asthma. And there's also another phase. In addition to the activation, there's going to be the perpetuation. So when these substances, the histamine, the prostaglandins, and the leukotrienes are released, there's going to be an increase in the blood flow, causing vasoconstriction and also fluid leaking from the vasculature and the attraction of WBCs into the area, which causes bronchoconstriction. So that is what is known as the perpetuation. Well, it doesn't stop there. So when we have bronchoconstriction, what's going to happen as the inflammation progresses, and this are going to lead to mucus hypersecretion. So that's the reason why in asthma, you're going to have a lot of mucus, and there will be mucus plug formation as well. And then, of course, there's going to be smooth muscle contraction, which would lead to hypertrophy and hyperplasia. So the precipitating factor is the response by the body. And in this particular instance, it's going to be mediated by an immunoglobulin. And again, as I said, that immunoglobulin is known as immunoglobulin E. And this immunoglobulin, in turn, are going to stimulate the production of mediators. And these mediators are going to include histamine, prostaglandins, and then, of course, your leukotrienes. Now, I'm emphasizing this because of the fact that the therapeutic interventions of patients with asthma will deal with these particular mediators. Okay, so what are some of the recognized factors that triggers asthma? Well, the number one thing is a genetic predisposition, specifically a personal or family history of allergy. And these individuals could have histories of, for example, eczema or maybe hay fever, as well as asthma itself. Other things might be environmental factors, as well as respiratory infections. Certain respiratory infections, such as RSV or respiratory syncytial virus, is going to be a condition that can damage young children's developing lungs. And of course, as far as environmental factors are concerned, that might include low birth weight as well as prematurity. So patients who are premature or who were born with a decrease in birth weight are going to be environmental factors that are going to contribute to the development of asthma. In addition to that, it has been found out also that parental smoking actually is another predisposing factor for the development of asthma. Sometimes people say, well, I don't smoke inside the house, I smoke outside the house. This actually does not eliminate the risk. Many of the irritant chemicals in cigarette smoke are invisible, and unfortunately, they cling to the clothing. And so, despite the fact that people think that they're not exposing their children to smoke by smoking outside, that's not really true. All right. So there are other things, of course, that can trigger precipitating factors that can trigger asthma. And the uh, first one that I'd like to mention are your exercise. Now, why is exercise can be a risk factor for the development of asthma? Well, in particular, when we exercise, we usually breathe through our mouth. And therefore, when we breathe through the mouth, what's going to happen is it's going to cause the drying of the airways due to the cold air. And this would lead to shrinkage of the cells of the airway, which also triggers the inflammatory response. Okay, so again, exercise is due to cold air, the drying of the airways, because when we exercise, we usually are going to breathe through our mouth. So there's a tendency to bypass the nose in warming the air, and therefore this leads to cell shrinkage and therefore activates the inflammatory response. GERD, as well as or gastroesophageal reflux disease, as well as chronic sinusitis, also have been found to be triggers for the development of asthma. Of course, allergies, as well as emotional upset, and then environmental allergens, which are not only limited to tobacco smoke, but it could also include insects as well as plants and other fumes other than what comes out of a cigarette. And lastly, certain medications can trigger the development of asthma, in particular, nonsteroidal anti-inflammatory drugs. These are going to shut the pathways towards the production of leukotrienes, and therefore it becomes toxic to the epithelium. And the other types of drugs that are going to be most especially triggers for asthma are beta blockers. Now, beta blockers prevents bronchodilatory effect of catecholamines on the airways, and that is the reason why this could precipitate the development of an asthmatic attack. What are the most common symptoms of asthma? While cough is the most common symptom of asthma, with or without mucus production, and of course, it could be accompanied with dyspnea as well as wheezing. And the type of wheezing that is often found in asthma is going to be first on expiration. So we have an expiratory wheeze in the beginning. And this possibly will include inspiratory wheeze as well. But in the beginning, it's going to be an expiratory wheeze. All right. The other things, of course, is that cough is or could be the only symptom in some instances. As far as dyspnea is concerned, there might be tightness that may occur as a result of the inflammatory response, and this would lead, of course, to dyspnea. So there are some patterns as far as asthmatic attacks are concerned. Asthmatic attacks occur frequently at night or in the early morning. Now, the reason why this is because of the colder air that usually is associated during the night as well as in the early morning. And exercise-induced asthma also is going to be one that is going to occur during exercise. And sometimes the only symptom that they might have is also a choking sensation during exercise. The attacks may occur over days, or it could occur abruptly. And then, of course, whenever this particular attacks occur in a continuous manner, then this is going to be a severe situation known as your status asthmaticus. And status asthmaticus is severe, is a life-threatening condition, and therefore should not be ignored. All right, let's take a look at the first question over here. Let's take a poll. Very good. It's the mast cells that's going to precipitate the formation of histamine. Okay, let's go to the next one. All right, so the pathophysiology of asthma does not involve the destruction of the alveolar wall. This is something that happens in patients who have emphysema, but not in asthma. Okay, so the characteristics of asthma are going to be the production of thick mucus, the swelling of the bronchial membranes, as well as bronchoconstriction. So A, C, and A, B, and D are correct as far as the obstruction of the airway in the patient with asthma, but letter C is incorrect. Okay, so which of the following statements by the parent of a pediatric patient indicates further education is needed? Well, my child might become restless if he's having trouble breathing. This is a true statement, correct? So when a patient is going to have respiratory distress, obviously they're going to be restless. So this is a correct statement. I might hear my child wheeze during an asthma attack. That also is an accurate statement. Uh, I expect my child's peak expiratory flow to increase during an attack. When you have bronchoconstriction, you will have a decrease in your ability to exhale, and therefore there will be a decrease in the peak expiratory flow. And we'll talk more about peak expiratory flow in a little bit. So this is an incorrect statement, but frequent coughing can be a sign of an asthmatic attack is a correct statement. So letter C is the best response. Okay, so whenever you're reading the questions on your test, make sure that you underline or underscore those things that are critical as far as the STEM is concerned. And this does not is going to be very important. So, which of the following symptoms does not occur in acute asthmatic attacks? While chest tightness can occur, mucus plugging can occur, but bradycardia cannot or does not occur. Rather, tachycardia is going to be accompanying respiratory distress, and wheezing obviously is going to be expected. All right, there are some complications for asthma, and the complications are going to include status asthmaticus, which often results in hypoxemia. It could also result in complications of respiratory failure. This is if asthma, if left untreated, progresses to respiratory failure. And mucus that pools in the lungs and becomes infected can lead to the development of another complication, which is pneumonia. So always think about these complications when you're thinking or taking care of a patient who has asthma. All right, let's go through history and physical of the patient as far as assessment is concerned. To determine the diagnosis of asthma, the nurse must always try to determine the symptoms of airway obstruction if they are present. And so, what are some of those things that you need to find out? If there are symptoms of wheezing, coughing, and exacerbated by allergies as well as exercise and cold. So, you need to include this in your history taking. Also, try to determine if the symptoms are worse at night and early morning. Also, try to determine the history of the patient. If they have history of atopy, which would include like eczema as well as hay fever. And of course, nocturnal coughing or coughing during the night and disappears during the daytime. All these particular findings or symptoms that is elicited in history can contribute to the diagnosis of asthma. So as far as physical examination findings are concerned, this will depend on whether the patient is currently experiencing an acute exacerbation. So during an acute exacerbation, the patient might have a fine tremor in the hands due to a lot of times use of bronchodilators. And this might be accompanied by mild tachycardia as well. Now, patients will show some respiratory distress and often sitting forward to splint open the airways is going to be assumed by these individuals. And this is what is known as the tripod position. And the tripod position is putting the hands on the knees like this, and the patient leans forward. And this is a compensatory mechanism to make it easier for the patient to breathe. So that's a tripod position. On auscultation, obviously, there will be bilateral expiratory wheezing. And in life-threatening asthma, however, the chest may be silent. So if you're listening to a patient and you do not hear any breath sounds, it is not your stethoscope, it is not your ears that is at fault. It means to say that the chest is so tight that air is barely going in. This is, of course, an emergency. It is a manifestation of a life-threatening situation. All right, so the other signs are going to be signs of systemic hypoxia, which would therefore include restlessness, mental status changes, as well as cardiovascular manifestations. And if the patient now develops bradycardia and severe mental status changes with no wheezing, then this means to say that there is arrest that is going to be imminent. So, particularly in children with imminent arrest, they appear drowsy, they are going to be unresponsive, they become cyanotic, and they could also become confused. And of course, bradycardia may also occur. So if bradycardia occurs, that means to say that there is an indication that severe respiratory muscle fatigue has occurred, and therefore it becomes an emergency. So how do we diagnose asthma? When asthma is initially suspected, the first step in the diagnosis is conducting a PFT, or a pulmonary function test. And the most important measurements that we're going to take in these patients are their forced vital capacity, also known as FVC. And FVC is the total volume of gas exhaled. Let me just write that down. After a forced maximum expiration. Okay, so that's the force. You're trying to ask the patient to have a forced maximum expiration. So we're going to measure this by asking the patient to take in a deep breath. Then we ask them to blow, 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 until they can no longer blow. This is forced expiratory, forced vital capacity, I'm sorry. And FEV1 means to say that this is going to be the forced expiratory volume at 1 second. Right? So the 1 is the 1 second. So the forced expiratory volume in 1 second. So these two are the most important things that we're going to be measuring in the pulmonary function test laboratory. Now, in an emergency, the quickest way to measure airway obstruction is going to measure the peak expiratory flow rate. So this is also known as PEFR, the peak expiratory flow rate. And this is essentially the fastest and the hardest a person can exhale after a full inspiration. So it's kind of like a bedside pulmonary function test. It's not quite as reliable, but very useful in emergency setting. So what is the normal PEFR, or the peak expiratory flow rate? Well, it should be greater than 70% of the predicted peak flow of the client's age. So we're not going to be able to memorize this because there's going to be a nomogram that you would have to refer to based on the patient's age. But again, after checking on the nomogram, you're going to determine if this is going to be at least 70% of the predicted peak flow for this particular age of the patient. Okay. So remember the 70% of predicted peak flow. All right, other measures to diagnose, of course, asthma includes your pulse oximetry, which can be useful in assessing the severity of an asthmatic attack or monitoring for deterioration. And of course, we could also have laboratory values that would help us in diagnosing the presence of asthma. So your urea and your electrolytes are obviously not going to detect asthma itself, but it's going to determine if there are going to be side effects caused by your drugs that are usually given to these patients. And the one that we are interested as far as electrolytes is concerned is serum potassium. And I'd like for you to remember this because this is a very, very common question in the Nclex. And a drug that we use, salbutamol in particular, causes hypokalemia. Now, the reason why it is hypokalemia is because salbutamol causes the potassium to go into the intracellular space, which therefore can cause hypokalemia. All right? ABGs for obvious reasons, and of course, this may help reveal hypoxemia as well as respiratory acidosis. An ECG usually will reveal sinus tachycardia, and it could also be as a result of drug effects. And then, of course, chest X-ray and other special tests that we could do would include your spirometry. So this is going to be very useful. Spirometry is a diagnostic method of choice to show whether or not there is obstruction. Okay, so those are the tests that are going to be included in diagnosing asthma. So let's go to another poll. Okay, so in here we have again a very important word in the stem of the question, and it is early warning signs. Early warning signs. So remember that cyanosis is a late sign, so we could eliminate that, right? Easily fatigued with physical activity, this might be true. A reduced peak flow meter reading, this is going to be late. It's not early. Nighttime coughing is going to be something that would be a early warning sign. And of course, wheezing or cyanosis is not, and wheezing with activity would also be an early warning sign. So A, B, and E are all early warning signs of an asthmatic attack. A reduction in peak flow as well as cyanosis means to say that these are signs and symptoms of an active asthma attack that would require medical treatment. Okay, so let's take a look at this question. Which result would be most concerning for a patient experiencing an acute asthmatic exacerbation? All right, so again, a normal pH for you to be reminded is 7.35 to 7.45, and anything that is less than 7.35 is going to be acidosis, and anything over 7.45 is alkalosis. And the PCO2 is a function of the respiratory system, and the normal values are 35 to 45. And if it is less than 35, this is alkalosis. And if it's over 45, this is acidosis. All right. So letter A, the pH of 7.32 is less than 7.35. So this is acidosis. A CO2 of 50 is going to be acidosis. A pH of 7.40 is normal. A CO2 of 34 is alkalosis. A pH of 7.42 is normal. A CO2 of 42 is normal. A pH of 7.37 is normal. And a PCO2 of 35 is normal. And PaO2 could be 85 to 95 is the normal. So the one that is worrisome over here is letter A, because it demonstrates that there is respiratory acidosis. So letter A is the correct response, and it looks like all of you got that correctly. Very good. Okay. Okay, let's take a look at this question. The ABG for a child with severe persistent asthma shows a pH of 7.28 and PCO2 of 50, bicarb of 25, which assessments are consistent with this ABG. Okay, so this pH of 7.28 is acid dosis. CO2 of 50 is acidosis. This bicarb is going to be normal because normal is anywhere from 22 to 26. So we have respiratory acidosis. Okay. So let's see what are the symptoms of respiratory acidosis. What do you see in a patient who is experiencing respiratory acidosis? Would they have rapid deep respirations and paresthesia? Now, paresthesia usually is going to be associated with a decrease in CO2. So, but we have an increase in CO2. So this could not be it. Slow respirations, nausea, and vomiting. Now, if it is going to be slow respirations, this usually is going to depress the respiratory system, and the slow respirations are usually going to be associated with acidosis as well. Disorientation, headache, and flush face, all these are going to have are responses to acidosis because an increase in acid has a depressant effect on the central nervous system. Therefore, it causes disorientation, and the increase in carbon dioxide will usually cause vasodilation of the cerebral and peripheral vasculature, and that would be why a patient with this particular blood gas would be flushed as well as experiencing headache. So this might be correct. And then, of course, Kussmaul's respirations and muscle twitching. Kussmaul's respirations is usually associated, again, with acidosis, but it usually is more associated with metabolic acidosis, not respiratory acidosis. So the correct or the best response over here is letter C. So I want you to remember that whenever you have acidosis, what you're going to have is you're going to have vasodilation of your cerebral and peripheral vasculature. And this would lead to headache as well as facial flushing. To classify asthma, the doctor usually will consider the signs and symptoms and how severe they are. And usually it is going to be classified into 4 general categories. The thing to remember is that most patients don't reach a certain level and stay there. So they change over time in response to triggers. This is why it's important to keep monitoring and managing the asthma of the patient, even when it seems to be under control. So the classifications are grade 1, grade 2, grade 3, and grade 4. Now, with grade 1, you have intermittent asthma. So the symptoms are going to be 2 times per week or less, and the nighttime symptoms are once a month or less, and the peak flow is going to be 80% or more of the maximum level. So these are going to be mild attacks as far as the asthma is concerned. But look, when you go to grade 3 and grade 4, you now have your 60% to around 80% of your maximum best, but there are more frequencies of symptoms. So it's more than 4 times per week. And as far as nighttime symptoms are concerned, it's going to be 4 times per month as well. So this is just an idea for you to be able to classify patients who are presenting with asthma. So the treatment of asthma involves several pharmacologic interventions, and the pharmacologic interventions are going to be of several kinds. And the first one are going to be your SABAs, and SABAs are known as short-acting beta-2 agonists. Short-acting beta agonists. All right. It's worth defining what an agonist is and what an antagonist is. When you say agonist, that means to say that you're increasing the effect of something. When you're antagonizing, you are blocking the effect of something. All right. So we have two kinds of receptors in our lungs. We have, or in the body, I should say, and there are alpha and beta receptors. And they are receptors to adrenaline or norepinephrine. All right, so where's adrenaline released? It's a hormone that's released by the adrenal gland. And when they circulate in the body, they are now going to, in order to take effect, enter into receptors or doors. So if they enter into a receptor marked alpha, or they could enter into a receptor called beta. But alpha receptors are of two kinds, alpha 1 and alpha 2. While alpha 1 are rich in or abundant in blood vessels. What is the action of adrenaline on blood vessels? It constricts them. So if it constricts them, there's going to be an increase in blood pressure. Your alpha 2 receptors are more abundant in the brain and other areas of the body, but we're more interested in alpha 1 receptors at this time. Okay? Now, if epinephrine now enters into the beta, there are two types of beta 1 and beta 2. Beta 1 receptors are very abundant in the heart. And when they enter into the heart, when adrenaline enters the heart, what happens is it increases the heart rate, and it also increases the force of contraction. Beta 2 are doors or receptors that are abundant in the lungs. And epinephrine, when they go into the lungs, they're going to cause the following. They're going to cause bronchodilation. All right, this lays the foundation of the understanding of your beta agonist that we're going to be using in patients who have respiratory distress. Okay? So whenever you are giving drugs, you want to have an increase of your beta 2 effects. So that's why you call them beta agonists. So beta agonists are drugs, therefore, that increases the effects of epinephrine into the lungs and therefore could cause bronchodilation. Okay? So the most common short-acting beta agonists that we're going to be using are the following. or I'll come back to this one, albuterol. So this is a short-acting beta agonist. And when we say short-acting, that means to say that it acts right away. Beta means to say that it goes to the beta receptors. Agonist means to say that they're going to increase the effect of that beta stimulation, which is bronchodilation. All right? So these SABAs are effective or are going to be first-line medications for acute treatment in asthma symptoms and exacerbations. They're also going to be used in conjunction with long-acting beta agonists, as well as other drugs like steroids and other drugs that we will be talking about later on. So again, an example of some of these drugs will be albuterol, and the trade names Acuneb, ProAir, HFA, and Ventolin are the ones that are very common. And it could also include your metoprolol, levalbuterol or Supinex, and perbuterol or Max Air. So these are the common SABAs or short-acting beta agonists. Again, why is it short-acting? Well, the reason why it's short-acting is their onset of action is under 5 minutes, and they could last up to 3 to 6 hours. All right? Okay, so let's go back to this one. The other thing that is going to be part of medical management of patients with asthma is going to be the use of anticholinergic agents. Okay. So when we have our autonomic nervous system, we have two branches. We have our sympathetic nervous system, and this is the one that releases the hormone adrenaline. So we just talked about those receptors before. We have alpha receptors and beta receptors. And in the beta receptors, in B2 receptors, it causes bronchodilation. All right. The parasympathetic nervous system, on the other hand, is going to be of two kinds, the muscarinic and the nicotinic receptors. All right, so muscarinic receptors are those that are going to cause bronchoconstriction. So parasympathetic nervous system acts by a substance or another hormone that is released called acetylcholine, and that's why it's called the cholinergic system. So when acetylcholine is released and goes into your muscarinic receptors, it causes bronchoconstriction. So wouldn't it be logical then that if we have drugs that block this, then that means to say that we can have bronchodilation. So if I block this, we will not have bronchoconstriction. So anticholinergics, therefore, inhibits the muscarinic receptors and therefore reduces the tone of the airway, causing the airway to dilate. All right. Did I confuse anyone as far as the sympathetic and the parasympathetic nervous system? Let me just repeat that because some people might have missed that. The sympathetic nervous system is mediated by a hormone, And that hormone is what is known as adrenaline. So I hope that you got that correctly. Adrenaline, in order to exert its effect in the body, has to enter into doors, and these doors are called receptors. And we have two kinds of receptors. We have what's known as alpha receptors, and we also have what's known as beta receptors. Is that understood so far? And alpha receptors are of two kinds, alpha 1 and alpha 2. Alpha 1 is abundant in blood vessels. Alpha 2 is abundant in the nervous system. So we're going to be interested over here in the blood vessels. It causes vasoconstriction. If adrenaline goes into other doors marked beta, and there are two types of beta, beta 1 and beta 2, and they're easy to remember. We have one heart and two lungs. So beta 1 is abundant in the heart. If adrenaline goes into the heart, it causes tachycardia, and it also increases the force of contraction. And in beta 2, these are abundant in the lungs. And the entry of adrenaline into beta 2 receptors causes bronchodilation. Is that clear so far? Hello?
Yes.
Okay, great. So the parasympathetic nervous system is one that exerts its effect by releasing another hormone called acetylcholine. And acetylcholine can enter into two types of doors, muscarinic and nicotinic receptors. This one is more abundant in the nervous system, but the muscarinic is going to be abundant in the bronchioles, and it causes bronchoconstriction. So in order to deal with asthma then, what we're going to have to do is to increase these things right here. And so anything that increases this effect is what is called a beta agonist. And we want to block this effect. And therefore, this is what's called an anti-muscarinic or anticholinergic. Okay, so do you understand now why we use beta agonists and we use anticholinergic agents? So your anticholinergic agents, for example, would be your Atrovent, which is ipratropium, and they're easy to identify because they end up with the suffix tropium, ipratropium. So that's Atrovent. And the other one is tiotropium, which is Spiriva. Thiotro. Okay? All right. So now we understand why we use anticholinergic agents, and we also use beta agonists. So that's exactly these things that we had talked about. We use short-acting beta agonists as well as anticholinergics. Now, the other drugs that are going to be used in the management of patients with asthma are corticosteroids. Now, what are steroids and what are the actions of steroids? Now, steroids are actually things that interfere with the immune system response. What do I mean by that? Okay. So let's say that this is a cell, a white blood cell, and the white blood cell is going to contain some packets right over here. And one such packet that they carry is a poison called lysosome. So it works this way. Let's say that a germ or a microorganism enters the body and the protein is different. This WBC usually will invaginate itself, meaning to say that it's going to form this action and it will capture this microorganism to go into the cell. So the cell is trying to capture this microorganism. Once this microorganism enters the body, what's going to happen? I mean, the cell, I should say, the cell now is going to rupture this bag. It kills itself, but it also kills the microorganism. All right? So this is going to be a normal way in which WBCs are going to fight infection. Now, when you give steroids, what actually the action of steroid is to make this wall of the lysosome thicker. So if it is thicker, will it burst easily? And the answer to that is no. This, ladies and gentlemen, therefore, is the reason why when you give steroids, what happens to your immune system response? Is your immune much better or is it depressed? And the answer to that is you will have a decrease in your immune system response. And the reason why, again, is because you have made the lysosomal wall thicker, and therefore it's hard to break. So understand then that if you are not able to break this lysosomal enzyme or lysosomal packet, you are not going to be able to fight off infection. So that's the number one consideration, therefore, that you're going to have whenever patients are using steroids. But steroids are useful to prevent this attack from happening so that no inflammation is going to occur. And therefore, it will improve airway function as well as decreasing the peak flow. So steroids are usually identified by the suffix "son" or "on." So whenever you see "son" or "on," these are going to be examples of your steroids. So let's say hydrocortisone. This is a steroid, and it is going to be effective in the management of patients with asthma because they decrease the WBC from initiating an inflammatory process. All right? So other examples would be methylprednisolone. So again, it ends with an "on," and the trade name for that might be Medrol or Solumedrol or prednisone. And the other one is beclomethasone or budesonide or pulmicort. So these are your steroids. Now, however, when you give steroids, they do not work right now. They're going to take their effect in approximately 5 to 7 days. So Is this going to be a good drug, therefore, to treat acute symptoms? And the answer to that is no. So steroids are not going to be for a rescue medication, but rather there are medications to prevent the formation of triggers or formation of attacks in patients who have asthma. Okay? So the rescue medications that we're going to give are going to be your SABA, your short-acting beta agonist, as well as your short-acting anticholinergics, such as ipratropium or Atrovan. Then steroids are going to be drugs that are most effective in preventing attacks from happening. And these are going to have a slow onset, but also a long-lasting effect. The other types of medications that we use for patients with asthma are leukotriene modifiers. So if you remember in the beginning of my discussion, one of those inflammatory mediators that we had talked about included histamine, as well as prostaglandins, and also leukotrienes. So leukotriene agents or anti-leukotriene agents or modifiers are potent bronchodilators that also dilate blood vessels and therefore are going to be effective in treating attacks of asthma. So examples of these would be anything that ends with a Lucas or leukotriene modifiers. So an example of that, there's two in the market, is Montelukast, and the other one is Saferlukast. So again, they end in the suffix Lucas. Your Montelukast is singular air. That's the trade name. And Saferlukast, the trade name is Accolade. So some of you probably have already had experience in giving these medications. All right. So we have talked about short-acting beta agonists, your anticholinergics, your corticosteroids, your leukotriene modifiers, and now we're going to do the newest drugs that are going to be used in the management of patients with asthma. And these are known as the immunomodulators. Immuno, meaning to say that they're going to modulate the immune system. And they are actually drugs that prevents IgE from binding. And therefore, if you stop IgE, you're now going to stop the inflammatory process. An example of these is any drug that ends with MAB. So this is a monoclonal antibody. Omalizumab is an example of that. Omalizumab. MAB. Okay, so this is a medication that usually is given as a subcutaneous injection. All right, so when patients are taking medications to manage their asthma, sometimes they're going to be taking medications like SABA, as well as steroids and leukotriene modifiers and immunomodulators. There is a rule of thumb that as far as the sequencing is concerned, always administer bronchodilators first. So bronchodilators have to be given first before the other drugs, such as corticosteroids, for example. So if you have orders for a bronchodilator and a steroid, you need to give the bronchodilator first, wait for 5 minutes, and then you would give the steroids. All right. So why is that so? Why do we give bronchodilators first? Now, if you give steroids first, what's going to happen is you're going to coat the respiratory system. The bronchodilators are going to have a hard time being absorbed. And that's the reason why we give the bronchodilators first for two reasons. Number one, it's going to be rapidly absorbed. And number two, it's going to dilate the bronchioles, and therefore, when you give the steroids, it will be a lot easier for the steroid to reach its particular target tissue. All right? So always make sure that you administer the bronchodilator first, and then 5 minutes later on, you're going to give the corticosteroids. Okay, so your beta-2 agonist could also be your long-acting agonist. So they're LABA. So LABA means to say it's a long-acting beta agonist. And a prototype of long-acting beta agonist is your salmeterol. You could also have your formoterol, or formoterol, indacaterol, olodaterol. The thing is that they're easy to identify because they usually are going to end with the suffix -terol. So as you notice, salmeterol, formoterol, formoterol, indacaterol, olodaterol. So these are going to be medications that are long-acting. So are these medications therefore given to rescue an acute attack? And the answer to that is no. It usually is used in conjunction with other medications such as steroids to control the symptoms of asthma and prevent bronchospasms in patients with asthma. All right. So let's be mindful of the side effects, because you remember that if we are now trying to increase the effectiveness of beta-2 receptors, there's also a tendency that when you increase your beta-2 receptors, that you might influence your beta-1 as well. Okay, so you increase beta-2, that's agonist. You could also increase beta-1 as a result of that. So what are the most common side effects of these medications? Well, headache, hypertension, neuromuscular, as well as skeletal pain. And that's because of the overstimulation of beta-1. Okay? All right. I always, as a nurse practitioner, I've always been taught that in managing patients, I always need to remember aim. And I'd like for you to remember that as well. This is a memory trick for the management of patients with acute asthmatic attack. And this will clue you to what medication is going to have to be administered first, second, and third. So the first one is going to be albuterol. So albuterol is going to be a beta agonist. The second one is ipratropium. You remember this pium? This is an anticholinergic. And then, of course, the M would be your methylprednisolone. So always remember that steroids are going to be last. Okay. All right, let's take a look at inhaled steroids. Well, inhaled steroids are a form of steroid that is going to be used for the treatment of children and adults with asthma. And they could be used in nebulized or inhaled form. Um, when we use it in inhaled form, the dose is going to be the least because inhaled steroids get retained in the airways with minimal amounts reaching the body. And so inhaled steroids have sometimes been, what do you call that, have difficulty being absorbed. So the inhaled steroids are going to work the same way as oral steroids work. They differ in how they're used to treat asthma. Okay, so let's take a look at inhaled steroids. When they are delivered directly to the lungs, the steroids require smaller doses. So this would result in fewer side effects, and therefore they're going to be safer for long-term use. When you give oral steroids, because they're going to be used systemically, meaning to say they're distributed throughout the bloodstream, they would require larger doses. And at the same time, they're going to have more side effects. And therefore, they're going to pose a lot of harm as far as long-term use is concerned. So therefore, oral steroids are going to be reserved for severe cases of asthma. All right, so we favor inhaled corticosteroids. And the ones that are going to be common here in the United States are Alvesco, Asmanex, Flovent. So these are the ones that ends with onide or azone, as I said, onide or azone or zone. These are your inhaled corticosteroids. And they come in three forms. The first one is going to be your HFA. This is your, it stands for hydrofluoroalkane inhaler. And it could also be a dry powder inhaler or DPI, or it could also be in a nebulizer solution. So those are the forms as far as inhaled steroids are concerned. All right. The medical management also are going to include conservative measures, which includes psychological support, weight management, allergen immunotherapy, meaning to say that if the patient has known allergies, that they're going to be treated for that, monoclonal antibody therapy. This bronchial thermoplasty is something that I'm not familiar with, but apparently it is a alternative treatment as far as asthma is concerned. And then, of course, smoking cessation and occupational change. Okay, so this particular drug is a combination of, you know, albuterol. So if you can identify that, what is that? It is the SABA, right? Erol. And how about the ipratropium? What would that be? What's ipratropium? It ends with opium, so which means to say that this is going to be an anticholinergic agent. So usually this is going to be a drug that is going to be used in combination. And when it is used in combination, it is going to increase some risk. So letter A, I'm at increased risk of cataracts if I use this medication. Well, actually, anything that contains an anticholinergic agent predisposes an individual to narrow angle glaucoma, not to cataracts. Okay, so it is not cataracts that they are going to be at risk for development, but they are going to be at risk for glaucoma, narrow angle glaucoma. It interacts with some BP medications. That is correct, because if you remember, your beta agonists are going to increase their action on beta receptors. And therefore, this is correct. Letter C, I can take this hourly as needed for shortness of breath. Remember that this combination is actually long-acting medications, and therefore they're not given as rescue medications. They usually are administered 4 times a day. And then, of course, letter D, this drug should not be used during pregnancy, and there is going to be no data or use in pregnant women. However, there is a possibility that this might be teratogenic. Okay, let's go to the next one. Okay, so let's take a look at this question. The patient's inhaler contains budesonide. So what is budesonide? So this is going to be a steroid, right? It's an onide. And if it is a steroid, what happens when you give it orally or through inhalation? Well, there's going to be risk of decreasing your defenses in your mouth. And one such infection that can occur as a result of exposure to your steroids is going to be thrush. So thrush is going to be a correct response. And that underscores the importance that whenever you have an inhaler that contains a steroid, you must always ask the patient to spit and then rinse their mouth in order to prevent the development of thrush. The other thing that needs to be done is to enhance the delivery of these steroids. And there are several things that you could do. Now, a peak flow meter is a meter. It is something that would measure your expiratory force volume. So that would not be it. Incentive spirometer, I think you all know that. This is not going to be a delivery method for your steroids. But a spacer is going to be something that is going to be an adjunct to the administration of respiratory drugs. I'm sure that all of you have seen a spacer, but let me just tell you what the reason is why we have a spacer. So if we are going to have the medication blown this way and we have this device called the spacer, what's going to happen is that the vapors or the drug is going to therefore stay here longer, and thus the patient can have better opportunity to inhale this particular drugs. So it will have more opportunity for the patient to get the drugs going into the lungs. The problem with regular inhalers is that it needs to be timed sequentially with the breathing pattern. And that is why a spacer is much better than a regular inhaler. Okay, so a beta agonist is going to be the one that is going to be useful for managing acute attacks. Okay, so you're talking to a mother and you're evaluating the management of her child. And she says, my child uses her inhaler about once or twice a week. Well, this is not bad. She usually has to use her rescue inhaler 4 times before improving. This is bothersome because that means to say that the patient should have additional medications prescribed to her in order to prevent this from happening. And then, of course, letter C, this is about above 70%, so this is good. And letter D, she takes breaks in gym class to catch her breath. This is going to be expected. So letter B is the correct response. Okay, so the correct answer here is letter C. Always remember that the nursing process says that you have to assess first before you intervene. And so letter C is assessment. Letter A is the correct intervention. However, it's not the priority. The priority is you need to listen to the patient's chest to make sure that there is still exchange of air, and also to assess the patency of the airway. So the correct answer is letter C. Patients with asthma requires a lot of patient education. And so the topics that are going to be important is going to include educating the patient regarding the nature of asthma, as well as methods of treatment, and also about medications like long-term controllers, short-acting medications, and quick relief medications, as well as helping the patient identify the causes or triggers to an asthmatic attack, and therefore measures or strategies to prevent it. We also need to emphasize that pursed lip breathing is going to be very helpful in easing dyspnea whenever it occurs. So pursed lip breathing is going to be important. And for those of you who don't understand pursed lip breathing is exactly that. You purse the lips, and that is to control your expiration. Because when you rapidly exhale, what's going to happen is that the alveoli will collapse all of a sudden. It will be harder to breathe again. So it is controlled expiration. So you do that by, that is pursed lip breathing. And then, of course, the importance of exercise, and also making sure that the patient take amounts of fluid that is going to keep secretions thin. So it is important that they have adequate amounts of hydration, as well as relaxation techniques. And of course, if the patient smokes, then smoking cessation is going to be important. One other intervention or education that you need to teach patients is about peak flow meters. So peak flow meters measure the highest airflow during a forced expiration. So the patient has got to be taught to do this daily. This is recommended for patients that have moderate or severe persistent asthma. And if the peak flow monitoring is used, it helps to measure the severity, and when added to symptom monitoring, indicates how much there is control of the asthma. So how are you going to teach a patient the steps for peak flow monitoring? Well, the first thing is, if you notice that there is going to be a indicator at the number, at the lowest number right over here, we're going to place the indicators to the lowest number of the scale, and then ask the patient to stand or sit upright, and then ask the patient to take in a deep breath. After taking a deep breath, place the meter above the tongue, and you ask the patient to close the lips around the mouthpiece and blow as hard as possible. We ask the patient not to cough or speak during this time because it will cause a false reading. And now we're going to check the number that is displayed on the scale, and we're supposed to repeat it, the procedure 2 times, and record it. So this is exactly how you would teach the patient to do the peak flow monitoring. Now, the peak flow meter might also look like this. So in some patients, this is going to be the peak flow meter. As you could see, this is going to be at the base. You put this at the base at the beginning, and then ask the patient to take in a deep breath and blow as hard as possible. So that would be the peak flow of the patient. Okay. The correct answer here is letter C. And why is letter B incorrect? Letter B is incorrect because you want to make sure that the patient exhales as hard as they can onto the device. Option A is wrong because this device monitors how controlled the patient asthma is and if it is getting worse. And lastly, letter D is wrong because the flow rate of 90% of the personal best is a good reading. Remember that the good one is 70% and above. Okay. So some of you answered letter A. Now, you want to exhale as forcefully or as hard and fast as possible. Over here, it says exhale slow. So that would not be the peak flow. Uh, and therefore, the correct answer is letter D. Okay, letter D. Okay, so the suffix Lucas is the one that is going to be specific for leukotriene, anti-leukotriene agents. So the correct answer is letter D. Erol is going to be beta agonist. Filin is, of course, aminophilin derivatives. And tropium is going to be an anticholinergic agent. Okay, so there are some important things that you need to um, teach patients about environmental measures to control asthma. So the following are suggested: cover pillows and mattresses with allergen-proof covers. They're also advised to wash all the linen at least once weekly in hot water, and also to keep the dress in a closed closet because it prevents it from being contaminated with dust and other triggers. The vacuum and dust the room weekly, and while doing it, they should wear a mask. Remain outside of the room during cleaning if you have a severe dust allergy, and if possible, air conditioners and keeping the windows closed will limit the amount of exposure to known allergens and triggers. Change the filter of the air conditioner frequently and avoid both active and passive smoking. Other patient education is: what if a trigger is exercise induced? Well, the patient doesn't need to quit exercising. This is important to emphasize because the more they are exercising, the more it is going to contribute to their overall health. And to help decrease the chances of an attack, what they could do is they need to warm up before exercising for at least 10 to 15 minutes. And then they could really take in a short-acting beta agonist before exercising. So again, this is a preventive measure, taking in an short-acting beta agonist before exercising. And then because of the fact that the cold air is the one that precipitates exercise-induced asthma, we teach them to breathe through their nose instead of their mouth during cold days to warm the air before it enters the lungs. Remember that cold air can make the smooth muscles around the airway constrict. And then lastly, avoid exercising when sick, particularly with a respiratory illness. Do you remember what I told you that when you are assessing a patient and you cannot hear any breath sounds, it's not going to be not your stethoscope is the problem, not your ears is the problem, but rather the patient is severely bronchoconstricted and therefore they're going to have inaudible breath sounds. This is going to be a manifestation of severe bronchoconstriction. So the correct answer is letter D, inaudible sounds with ineffective cough. Okay, so whenever you're giving cromolyn, unfortunately, this drug is going to have those side effects. In addition to having a horrible taste, it could also cause the patient to sneeze, and sometimes they complain of burning in the nose as well as itchy and watery eyes. Uh, Make sure that you reassure the patient that these are temporary side effects and they are going to be harmless. Okay, so the correct answers are going to be letter B. You remember preventive measures includes the administration of a beta agonist, short-acting beta agonist before the exercise, not after the exercise. And then, of course, avoid exercising during respiratory illness. Okay, very good. Salmeterol is going to be a bronchodilator, and fluticasone is going to be a steroid. So it's important that you need to give the beta agonist first, and then wait for 5 minutes, and then give the steroid. All right, so the answer is C. When a patient has an acute asthmatic attack, they will need a medication that will act quickly to open the airways, right? So this would be include therefore the administration of SABA or short-acting bronchodilators, an example of which is albuterol. And another type of a short-acting bronchodilator is an anticholinergic bronchodilator called ipratropium. Um, but, but theophylline is a bronchodilator, true, but it is not for quick relief. Going back to tiotropium, this is a bronchodilator, but this is long-acting anticholinergic bronchodilator. And cromolyn, of course, is a steroid, and therefore it will not cause any relief for the patient at this time. Okay, we mentioned about the severe asthma, and that would be status asthmaticus. I just wanted to include that here as far as the signs and symptoms of status asthmaticus. And they include severe bronchospasm and dyspnea that they could not even speak. So when it precludes speech, that means to say that they're severely dyspneic. And when they have accessory muscles, as well as respiratory rates above 35, heart rate above 140, and a PEF of less than 100 liters per minute, and the retention of carbon dioxide, all these are going to be signs of status asthmaticus. So status asthmaticus is usually treated with bronchodilators as well as epinephrine and steroids. And in addition to that, they would also require intubation and mechanical ventilation sometimes. Okay, so that ends the presentation. So let's now go to the case study. So I hope that you had the case study link, or if you are going to answer that later on, I provided you with the link in the chat box. So the situation is the nurse cares for a 23-year-old male in the ER experiencing acute onset shortness of breath. The client reports shortness of breath and chest tightness that has progressively worsened for the past 2 to 3 days. He has a history of seasonal allergies, a non-smoker, and lives at home with his mother, who is a current smoker. Denies fever or vomiting, describes feeling fatigue, and has a dry cough. At 11:15, there's audible and expiratory wheezing heard throughout the lung fields bilaterally. There's increased respiratory rate, capillary refill less than 3 seconds, skin warm to touch, chest wall is symmetrical. Client sits upright and leans forward, resting his hands on his knees in tripod position, and speaks only a few words between breaths. Tenderness on palpation, trachea is midline, and labs drawn, checks X-ray ordered. And you could see the pulse is 98, respirations 26, blood pressure 114/78 with an O2 saturation of 95. So The first question is, which findings requires immediate follow-up? Which findings require immediate follow-up? Okay, so in these types of questions in the new Nclex, you're going to be right minus wrong. So it's much better for you to be very conservative in choosing your answers, okay? So as far as shortness of breath, that would be a concern. Chest tightness is also a concern. The respiratory rate, which was, I think, 26, is also going to be a concern. And of course, the dry cough, all these are pointing towards your respiratory system and tripod positioning. Remember, tripod positioning is placing the hands of the patient on their knees and leaning forward. And these are all manifestations of respiratory distress. And of course, speaking only a few words between breaths. The blood pressure is not bad. It's 114/78. So that would not be appropriate to choose. Tenderness of the chest wall does not have anything to do with asthma or this shortness of breath, so we could ignore that. So those are the proposed correct responses. All right. So for each potential finding, click to specify if the finding is a risk factor or not a risk factor for asthma. Okay, so let's take a look at the risk factors. All right. So your risk factors would include family history. That would be a risk factor, right? A history of allergies would also be a risk factor. Beta blockers would also be a risk factor because you remember beta blockers are going to cause bronchoconstriction. And then what else? Viral infections, smoking, obviously, is going to be also a risk factor. And overweight is also going to be a risk factor. Edema and diabetes are not risk factors for the development of asthma. And so this one would be like that. Okay. And now let's go to question number 3. So complete the sentence from the drop-down menu. And so let's see. The nurse should recognize that the client is most likely experiencing blank as evidenced by blank. All right, so the hallmark finding in asthma is going to be expiratory wheezing, right? Okay, so some of you said pneumonia, but look at the case study again. The temperature is only 97.8, and then the WBCs are this one. So there's not a possibility of it as being pneumonia. It's not pneumothorax because, again, the trachea is midline. If the trachea is midline, that means to say that there is equal expansion of both the right and the left lung. When you have pneumothorax, your trachea will move towards the area that is going be uh, to be intact as far as lung function is concerned. Okay, and that is why you can eliminate pneumonia as well as pneumothorax. And then, of course, the evidence for asthma among all these choices are going to be the wheezing because of the narrowing of the airways. Okay, so now there's a new finding, and that is that there's a chest X-ray that shows hyperinflation of the lungs with flattened bases at the diaphragm. So the question now is, which of the following interventions should the nurse anticipate, including in the plan of care? So select all that apply. All right, let's take a look at the correct responses. Giving oxygen is going to be okay, and giving albuterol is going to be okay as well, because this is going to be a beta agonist. Placing the patient in a supine position is not correct because this will worsen the symptoms of the patient. Aspirin, we know, as well as ibuprofen, are going to be triggers and therefore should be avoided. And then, of course, labetalol, alol, or lol is going to be a beta blocker. You remember that beta blocker causes bronchoconstriction, and therefore this should be avoided. And a lot of you answered offer oral fluids. Whenever a patient is short of breath, you should never give anything by mouth because of the risk of aspiration. Whereas it is true that patients with respiratory problems need a lot of fluids, you must never give anything by mouth if they are severely short of breath because of the risk of aspiration. Okay? All right. So now we have these orders. And the orders are monitor pulse oximetry continuously, albuterol 2.5 inhaler, ipratropium 250, peripheral IV, and instruct client on peak flow meter use for at least 2 times daily. So the question now is, if you are going to do all these actions, will you do them immediately? Will you do them within the hour? Or would you wait till the end of the shift? So they're trying to determine now, or to see whether or not you can prioritize. So let's answer that question. Okay, so let's see how you answered. Now, instructing the client on peak flow meter use, this could actually wait till the end of the shift. It's not something that you would have to do right away. So the proposed answer to this one is at the end of the shift. Now, administer 2 liters of oxygen. Obviously, that would have to be immediate. And administer Medrol, also going to be immediate, because it's not going to work now, but you need to have it start working or being on board right away. And administer albuterol and ipratropium. Of course, these are going to be immediate interventions that you are going to have to do. Instruct the patient on pursed lip breathing. Well, this is something that you don't have to do right away, but you could do it within the hour. And then, of course, instruct client on home medications. This can wait. And apply continuous oxygen. Pulse oximeter is going to be immediate as well. Okay, so how did you fare with that? I hope you did okay. And now let's go to the last one. The last one is going to test you to determine if you're going to evaluate the patient to see if the patient is improving, deteriorating, or unchanged, and what would be your appropriate intervention. So let's have this question. All right, I'm sorry that I didn't show you, I didn't give you enough time to see what the latest values are for the blood pressure and everything. But if you notice here at 1330, nebulizer treatments and Medrol given, deny shortness of breath or difficulty of breathing, lung sounds are improving, client can speak in full sentences, and no reports of fatigue. And as you could see, the pulse rates are improving right over here. with the respiratory rate also improving as well. All right. And the pulse oximetry doing that as well. So as far as I'm concerned, the patient is improving. And if therefore the patient is improving, then that means to say that we can now prepare the client to discharge for home. So letter A. So once again, I want to thank you for your participation in today's class. So we continue our class tomorrow, and I hope that you can attend again. So we're over time at this time, but anyway, if you have any questions, I'll be available to answer them for you. So once again, thank you so much. Have a good evening, and I'll look forward to meeting you again tomorrow at the same time and same station. Okay, thank you.